right, let's go ahead and get started. Welcome everybody. Some of you, for some of you, this is your second experience with Dr. Updike. For some of you, it's maybe your first. Dr. Updike will tell you a little bit more about himself, but let me just say a few things. CME credit is available for this talk as well as it was for the first one. So I don't need you to pop in your name and email and hospital affiliation if you've registered. The only people I need that from are folks who might be sitting next to someone who didn't actually register, because I get the entire list at the end of this. So we don't need to bombard the chat box with that. So if you are not registered and you're participating somehow, then just type in your name and email and your affiliated, your hospital or your clinic, wherever you are. And we are going to ask again to hold off on the questions during the talk. In fact, we're going to turn the chat box off so that Dr. Updike can fully concentrate on the talk. And at the end, we'll take questions if we have time. And Dr. Updike is willing to field any questions you might have if we run out of time, and you can email him those questions. So without further ado, let's go ahead and get started. I'm going to close the chat box and I'm going to mute myself and turn myself off. Are you ready, Dr. Updike?
Yes, I am.
All right.
Thank you. Okay, so I guess some of you were on the talk before. This is, it's definitely a different talk, but just as way of background, my name is Paul Updike. I work out of Buffalo, New York. I'm the medical director for an opiate treatment program, several here. I have a large clinical practice of buprenorphine. But I was asked to do a couple of talks. We, kicked it around, like what the topic should be. And one of the talks we did was on pain in patients with substance use disorder. And this one is this talk is focused on really kind of common problems that you might see in patients with buprenorphine. And this is something I've talked a lot about and talked to myself a lot about. Taking care of these patients is not always easy, and we're going to sort of talk about that a little bit. But one of the things I try to remind myself, the staff, about a lot, I say this phrase a lot, that we are treating patients with a serious life-threatening disease known as opiate use disorder or opiate addiction. And so that's the way that we need to approach this. This is a very serious and life-threatening disease. And I realize most of us basically know that at one level, but then we have to try to apply it then when we're taking care of patients clinically, that when something arises that, is aberrant or out of the norm, how do we address it so that hopefully we can continue to take care of the patient? Because this disease, when it is untreated, is fatal. When you look at the methadone literature, it's very stark, and actually the buprenorphine literature is pretty much the same probably, but the methadone literature is clear. When we discharge patients from a methadone program because of aberrant behavior, other drug use, behavioral issues, or whatever, their mortality rate increases sevenfold, 7. And there's really, not that many diseases that I would say where we say that happens. That's a very significant thing. And so this talks a little bit about trying to talk about how can we make this work. We can't always make it work, quote unquote. But there's a lot of times we can work through issues and get to a better place. And that's kind of what we want to focus on. So if we go to the next slide. And that's basically what this is going to talk about. A little bit about patients and starting buprenorphine, toxicologies, what they mean, how to interpret them, proper use, what to do with aberrancy, and that kind of thing. Next slide, please. And I'm sorry, I was asked, my favorite subject, me. I was asked to talk about a little bit about my background, and I did it the first talk. But I mean, there's a summary here, and really the long and the short of it is, I'm very blessed in the work that I do. I love my job. It was not what I intended to do. When I went to medical school or got my internal medicine residency training, I actually started working in a very small rural clinic that was part of our health system. And that's what I thought I was going to do. And then clinic was closing, and I didn't have a lot of other options. And I ended up working in our inner city a clinic, and it's called a mission clinic for the hospital. And it was right at the sort of the cusp of the opiate crisis. And I just literally inherited a whole clinic full of patients with opiate use disorder, almost literally. And almost really to survive, I started to learn about this, and I started doing a lot of research, met some great people who taught me, nothing formal, informal. And I started doing it in my practice. And eventually I became the medical director for our whole unit at Catholic Health. And, that sort of evolved over time. But it was not, what I intended. We've done a lot of things since then. I've been using buprenorphine since 2005. It's really the first provider in Buffalo. And I've trained hundreds of people on buprenorphine now. But, the reason I sort of bring this up is because it doesn't require, fellowship training. It doesn't require a lot of resources. I have had almost no resources when I first started to be able to take care of these patients properly, frankly. So it can be done well, and I believe it should be done primarily in primary care type settings. So it's something we can do, and it's just a matter of sort of learning how to work through some of the issues that come up. Next slide. All right, this is a little bit of our own local data. I'm sorry, I wish I had the update. I was trying to get that because it's kind of like bad news, good news, bad news story. And as I understand, it's a little bit of what's happening up there too. Unfortunately, our overdose rates have increased again in Erie County through this COVID crisis. But you can see what happened was 2012-13, that's the prescription opiate crisis for a county the size of Erie, 100 deaths a year. That was a lot. We had the I-STOPS law in 2014. That was a prescription monitoring, a lot of restriction on opiate prescribing with good intentions, decrease opiate prescribing because that was a problem. But the unintended result was patients who already have opiate use disorders, most of you know now, if we simply say to you now, you can no longer have pills, that has not cured them of their addiction. And so what happened here, as has happened across the country, is patients transition to other opiate use, illicit heroin use. And then in this area, that quickly became fentanyl and fentanyl analogs. And you can see our death rate tripled within about a year and a half. And that's what happens with this disease. It takes no prisoners. And, we really had a lot of targeted response in this county because of that. That, obviously got a lot of attention, and rightly so. And you can see, and our death rates were back down to about 100 last year. And the reason that the death rates decreased so much, most likely, it's easy for me to say because I was doing a lot of these trainings, but because our access to medication-assisted therapies in this county increased dramatically. Another methadone clinic opened in addition to that. And so that's what happens. This saves lives. Unfortunately, with COVID, we've had an uptick again. I'm hoping that's kind of a brief type of thing, but these interventions save patients' lives. Next slide. All right, so this is a little of basically our own data from Erie County. One of the things we did was we started doing waiver trainings, and I did them. And we got some feedback from people who would come. We did the half and half courses where it was half live. And this is the kind of thing that we got back really a lot. Like, okay, what we found in the data was providers will, if we can get them to go to the waiver training, there's a big step between going to a waiver training and actually prescribing. And there's a lot of, and it's reasonable, but there's a lot of uncertainty that a course doesn't just teach you everything you need to know, And so what we found was offering further assistance. We did some follow-up trainings, having mentoring really increases people's comfort level with actually prescribing buprenorphine. And to that point, I think the more that we learn kind of how to deal with difficult situations, I think, the more comfortable we then will be to prescribe to patients. Next slide. All right, I don't want to spend any time with this. This is the criteria for opiate use disorder. You all know it. Next slide. All right, I don't want to spend too much time on this either. In our area, there's tons of talk about harm reduction. It's a valid concept. And these, that's a broad, obviously, topic, but you can think of medication-assisted therapies certainly as falling into that category as well, where we're trying to reduce the harm, the most obvious harm, death in this case, but all the other associated harms. And so even if treatment is not going perfectly, improvement is better than the patient, inactive in their throes of addiction. That is no place for anyone to be. And that we want to get the patients out of those very, very dangerous situations that they're commonly in. Next slide. All right, so, I'm sure you all know this, but this is just a little bit of an overview. The literature is actually fairly clear. Like, some patients are better candidates for buprenorphine, I'm talking about here, than others. And patients who are very good candidates for buprenorphine are patients who have good psychosocial supports, older patients, patients who have used buprenorphine, meaning illicitly. A lot of providers will say, oh, they used illicitly, I'm not comfortable giving it to them. Those are actually good candidates. And patients who haven't used intravenous drugs. If you find a patient like that, they, generally speaking, do excellent with buprenorphine. Now, with all of that being said, that doesn't mean that if a patient has, say is an intravenous drug user, that doesn't mean we shouldn't try buprenorphine. So it's pretty much almost no, from my perspective, anyone with a diagnosis of opioid use disorder should be considered for medication-assisted therapy, which would obviously include buprenorphine. All right, next slide. Okay, so this is the deal. I kind of already said this, but this is the slide that I would like you to remember. If you forget lots of other stuff here, this is important. This is the mortality rate associated with untreated opiate use disorder. You can see the general population, and when we have untreated opiate use disorder, it's 5 times the rate that patients die, and we initiate medication-assisted therapy, and it gets back down to near what it would have been if they weren't using. So that's highly significant, and we need to keep that in mind as we're taking care of these patients. Next slide. All right, I don't want to spend too much time on this. Home induction, I've been doing this since 2005. I did one office induction my whole career, and I just never liked it. I've done hundreds of home inductions, and this is not primarily a talk about that, but I'm just putting that out there as some people are real strict with, I think they need to do an in-office induction. There's nothing wrong with that per se, but particularly in my practice setting and my experience would say that doing home inductions is very, very safe, is an excellent way of doing it. I think it's much easier to initiate patients that way. And it's something that, really you should be considering if you haven't in the past. It works very well. I've never had any issues. It's really all a matter of how we explain it to the patients, just making clear to them what the risks are, particularly the risk of precipitated withdrawal. And when you explain to patients who have an opiate addiction that if they don't, do it right, they're going to have withdrawal. I mean, generally speaking, they're not going to do that to themselves. So I've never had an issue doing it this way. And for my practice, it works excellent. Next slide. All right, this is a little bit of something to think about. And I don't know where everyone's at with this. I think of these treatments as indefinite. I mean, forever. I'm super comfortable with that. The literature's really clear. The methadone literature is extremely clear. Relapse rates before two years are very high. And usually what I say to patients is relapse after that are just high versus very high. And that's the reality of this disease. Does that mean that no one can ever get off these medications? That's not what I'm saying. But what I'm saying is not too many can actually, and remain abstinent for the rest of their lives. You're talking about, in general, patients who are younger, in general, because addiction is a disease of the young, but of course it's in all ages, but oftentimes younger patients, and we're saying they have to remain opiate free forever. It's not just like a year or two, it's the rest of their lives. And that's a lot of risk in there. And it's very, very risky for patients to be off these medications. And so the best measure, and there's not a lot of literature on this, and I've looked through it a couple of times, and not recently, and I should redo this, but there's such little guidance on this. The best thing I ever found was something from France, and maybe I like it because it mirrors what I was doing, but that the best measure of this is the patient, and not me. You know, so I don't usually talk to patients about getting off treatment. And if they start to talk about it, well, by all means, we should talk about it. But then we have to, you know, think about what's going on. A lot of the times the patients want to get off of treatment because their husband doesn't like that they're on it. They don't like seeing me. The co-pays are too high or whatever. And I'm just here to tell you, those are terrible reasons to get off. That doesn't usually work ever. For this to work, the patients have to be stable. They have to be stable in their recovery. And those are the kinds of talks I have to have with them all the time. If they're using other substances, including marijuana, I've never seen a patient get off buprenorphine and remain opiate free. And so again, that doesn't mean that could never happen. We're talking about relative risks and benefits here. So this is a very big decision is what I'm trying to say. And from my perspective, it's not something that ever needs to happen, meaning they don't have to get off the medication. And it really should only be considered, I believe, if the patients are feeling like they're ready to do it. Next slide. All right, so for our maintenance patients, and again, I mean, I just went over this, right? I believe that the patients, I mean, I have had patients on buprenorphine for many years. Our average length of stay, this is internal data for our methadone clinics, average length of stay, 8 years. And I think that's completely appropriate. So, you know, basically what it comes down to is we see these patients a lot. And so, you know, these are the routine things that people understand. You know, you need to have some boundaries. There should be regular toxicology screening. We're going to talk about this some more. Ongoing treatment, concurrent other psychosocial treatments as needed. And really following these patients a lot. I get to know these patients very well. I see them a lot. The 3 A's is actually the 4 A's, but I sort of changed a little for the addiction visits. The 4 A's was from the pain literature, Dr. Gorley, and it works great for sort of the outline of a progress note when you're seeing these patients. And it works great for addiction visits, really. And this is the sort of the skeleton of every visit I have. I ask them how they're doing in their recovery. I ask them if they're using other substances, if they're taking the medication that I'm giving them as prescribed. I ask these questions almost every visit, and I ask them about side effects. And, you know, a lot of these patients, I'm doing well, I'm engaged in self-help, I'm taking the medicine, I have no cravings, I don't have any constipation. Boom, that's a visit. And that's what we want. I say to the patients all the time, I love boring, love it, love boring, because that's why I like to hear that things are going all right. Now, obviously, it doesn't always work that way, but a lot of the times it does. A lot of the times it does, that these patients get started on the treatment and like there's never any issues. And that's very gratifying. Of course, it doesn't always work like that, but a lot of the times it does. Next slide. All right, toxicologies. Next slide. Oh yeah, if you could hit it again. You can hit all of them. I'm sorry. This one, I don't mean to have it like this. So, you know, this is a toxicology should be, right, it's supposed to be a clinical tool. It's not supposed to be the ticket for the patient to leave your practice. So when we start to think about this, we should think about a toxicology as something that is supporting our practice, that may be giving us useful information, that when we find results that are inconsistent or whatever, that this is a sign that something may need to be done, an intervention. For sure, we need to have a discussion with the patient. But it shouldn't be that, okay, your toxicology is abnormal, you're using cocaine, that means you can no longer be a patient here. Now, sometimes patients get to the point, like say, where maybe they can no longer be our patient. But from my perspective, rarely, if ever, should that be like first go around, like the first time that there's trouble. And it shouldn't just be based on toxicology results either. So some of this is a medical legal thing. But it should be that a toxicology is ideally is helping us to confirm they're taking the medications and to help us identify problems that we can then intervene with the patient on. That's what ideally they should be. Next slide. All right, so when you're thinking about buprenorphine, and I know hopefully this is very much review, but you want to make sure that you know your tests when you're talking about toxicology screening. Some opiates are not identified as opiates, like methadone, like fentanyl. And when you're doing a test for buprenorphine, you want to make sure you understand what the lab is doing. If they're doing an immunoassay for buprenorphine, it will just show positive. But when you're trying to confirm whether or not the patient's taking it, at least some of the time you want to do some of the confirmatory testing. This is the third bullet point where you see the metabolite norbuprenorphine. You want to make sure that that's in there, and that usually there should be more of the norbuprenorphine than buprenorphine. So that confirms that they're taking the medication. Because if the patients just add the buprenorphine to a urine, pretty much the test will just show buprenorphine. And so that's one way you know that the urine toxicology was false. So getting the norbuprenorphine with some consistency should be done. All right, next slide. All right. Other substance use. This is a big one. Next slide. All right. So it's real easy for me to say here from Buffalo that problems occur and try not to take it personally. But, you know, that's what I try to say to myself all the time. Many of the times, the kind of troubles that we're talking about here, particularly other substance use, is simply a symptom of the disease. They are seen as, by definition, they have opiate use disorder. In this case is what we're talking about. And by definition, they have a much higher risk of having other substance use disorders. So we should not be in any way surprised when our patients who have a known history of a substance use disorder of one sort struggle with other substance use. And so to my way of thinking about it, that this is a sign that there are problems and that we then need to make an intervention. And we have to, I think, recognize that just because I say to you, stop using drugs, you know, that doesn't work. I think we all know that. And so we have to have a plan, some patience, and weigh it against the third bullet point. I've already said this once before, I'll say it again, the third bullet point, which is we're trying to balance out here the relative risks and benefits. I have opiate use disorder. That is a serious life-threatening disease. And now I'm using marijuana. And my intervention for that is I'm going to discharge you. I would offer to you that that is not a reasonable intervention. We've now put the patient's life at risk. And that is not to say that particularly cannabis use is not significant, but it is not to the same level as the opiate use disorder in the vast majority of cases. And so, you know, I think that what we need to do is not bury our head in the sand, not just pretend like things are going to just get better on their own. Try to figure out what's going on with the patient, see what interventions that we can do. Maybe we need to, this is the fourth bullet point here, tighten the boundaries. This is something Dr. Gorley taught me. Okay, now I need to see you more frequently. I may need to do some more urine toxicologies. I may need to have you relink with a counselor or whatever, so that we can try to make this work, because there's a problem now. And what I want to do is address this problem while we continue your life-saving intervention, buprenorphine. And if that all is not working, to be very thoughtful about, okay, this has happened in my practice many times. The buprenorphine is simply not working. And I wasn't really planning on talking about this directly, but in our area here, because we have such high levels of fentanyl, it's honestly, this is my opinion, but I believe it's just simply it's a pharmacological problem that buprenorphine is just not sufficient to treat a lot of these patients. We have patients now I'm running into commonly who are using 2 or 3 grams, and it's really just fentanyl here a day. That's extremely high levels of use. And they don't do well on buprenorphine for many reasons. And okay, we have to be able to admit that when that's happening, but to make sure for me, and it's easy for me, I know I run an opiate treatment program, but that I transition them then to methadone. A lot of these patients do better with methadone. But what I don't want to do is say, oh, you're not doing well with buprenorphine, and so I need to discharge you to the street. I want to try to avoid that if at all possible. If at all possible. Next slide. All right, so this is just the reality of what I've already outlined. Our patients with an opiate use disorder use other substances at relatively high rates. Very common. Next slide. And what happens is the longer our patients are in treatment, and that's really just taking buprenorphine. But I mean, you could say, of course, if they're doing other work, engaged in other psychosocial treatments, right? The more the patients are engaged, likely the better this is. But simply by being engaged with us and being in treatment, their use of other substances, this is not opiates, other substances, decreases. And this is what we see a lot. This is very clear from the methadone literature. You know, we follow these patients out. One of the studies was just a terrific study from years ago showing that abstinence rates from cocaine use increase consistently in patients on methadone. The longer they are in treatment, follow them for 5 years out, and the abstinence rates continue to improve. Does that mean some people are using cocaine regularly, maybe even for years? Well, potentially. But again, I would argue that discharging them because of their other substance use is potentially a bad idea in regards to what that means, that they will now be using opiates. That's what that means, in addition to cocaine. And so the more that we have a chance to intervene with them, the better the outcomes are. And so it's like, how long can we hold out? That's why I'm always saying to the staff, do we got a little bit more in this? Can we come up with another way of maybe trying to make this work? I'm always trying to push us a little further, because I know what it means if we end up having to discharge the patient. That does not go well for them. Next slide. All right, so the diversion is a real issue. I was talking to another group this morning, actually, at our cancer hospital. Actually, this is such a common concern, opiates, buprenorphine. And I don't have any, you know, unfortunately, I don't have any great, you know, sort of, oh, I've unlocked the key to all the, you know, I've got the lock, I've unlocked it, problem solved, you know. This is an issue that we have to struggle with. But what I think is incumbent upon us is to struggle with it, okay? To recognize, yes, diversion of buprenorphine can happen. In fact, does happen. And then trying to sort of weigh out in our minds, like, what does this mean? What is really going on? Is there some way that I can make it such that the risk is less, and, you know, try to move forward? In my practice, the last couple of times where we've had some diversion of buprenorphine, it really isn't been like they're just dealing drugs. They're sharing the buprenorphine with other people in their household or, you know, in their friend circle who are struggling themselves. And so that's not to condone that, but like, that is understandable. And so I would offer to another approach would be, and this is what I say, particularly when, you know, it's in the household, like a husband and wife, have your husband come in here. There's no reason you have to keep doing this. I'll treat him too. And so then, you know, the problem is addressed and it's a win-win for everybody. And again, you know, it doesn't always work like that. We'll run into situations where sometimes people are just not taking the medication despite a numerous interventions. And in my experience, and I've already touched on this, nowadays, those kinds of situations are patients who basically are not responding to buprenorphine because their addiction basically is too severe, and they're selling buprenorphine. And so the intervention is to get them to a different level of care. And as I've already mentioned, to me, that is a methadone. You know, not to pretend like you can just keep giving buprenorphine even though they're probably selling it, but also to recognize what's driving that behavior. And, you know, maybe they don't accept that referral, and maybe I can't really keep going on like this, but at least it's been offered. At least it's been offered. And, you know, my experience is very positive. Usually when I sit down to patients and talk to them like this, I'm very worried about you. This is what I believe is going on. I believe you're selling the medication. I think it's probably because it's not working for you. I understand why you might be doing that. I can't be a party to that anymore. but I want to help you. I'll admit you to our opiate treatment program. And you know what? A lot of the times the patients take me up on that. And that's what I want. So that's the kind of way that I would suggest that we try to work through these things. Not to ignore it. When there's issues, address them. Recognize that a lot of the times it's just a failure of therapy and they may need referral to a higher level of care, so to speak. Next slide. All right, and so again, this is keeping the eye on the ball. What are we dealing with? Next slide. It's this. It's this. When we have problems, when we have other substance use, when I have concerns about buprenorphine, these are legitimate concerns. So in no way am I saying that they are not. But it is always, to me, it's measured against the real and ever-present danger of their untreated opiate use disorder. Okay, next slide. All right, next slide. I already did the pain stuff, but uncontrolled pain is a real big problem for these patients. Just to touch on this, 2 slides. Next slide. All right, next slide. I'm sorry, I thought I cut this out. Okay, the 4 Ps. This is my little thing of when I'm thinking about treating a patient who has a substance use disorder and has a pain problem. We want to optimize their pharmacology, their physical interventions, physical therapy, etc., procedural, surgery, blocks, etc., and their psychological interventions, treating the depression, cognitive behavioral therapy. When we do that, oftentimes the pain can be managed. Next slide. All right, so I don't know how common the treatment in pregnancy is in your area. I do this a lot, meaning treat pregnant women who have a substance use disorder, particularly opiate use disorder. And, you know, it can be a very emotional thing. It can be quite difficult for everyone involved, mother, staff. And my experience with it now is so positive, where it wasn't always that way. And this is one of these things that's developed over time, but because we have a large methadone clinic, because I see lots of patients with buprenorphine, we started seeing many more women in our hospital system who were pregnant and with opiate use disorder. And it really was an exponential increase over the last couple of years, to the point where we literally built a new NICU last year to take care of babies with neonatal abstinence syndrome. But the good news about all of that is that we do it very well now, meaning taking care of these women and their babies. And that's why we see so many of them now. And, you know, that's what we want. We want to turn what can sometimes be a very difficult situation into a positive situation. So taking care of these women can be a challenge, but is extremely, extremely important. When a woman has an opiate use disorder and is pregnant, the recommendations are that they start medication-assisted therapy and or continue it. So if they get pregnant while they're on it, they should not stop it. And by that, I mean methadone and buprenorphine. I do not mean Vivitrol right now. It's still not the recommendations, although you could continue Vivitrol during pregnancy. There's some understandings about that. But either of these treatments is reasonable to consider. And there's a lot that can be said, but it gets down to really, from my perspective, trying to match up the patient properly with a treatment that I think, you know, will work, meaning will be effective for them and that they can, you know, do. Obviously, there's benefits to the buprenorphine. That's a less invasive treatment in a way, but there's also a lot of benefits to methadone, particularly from a pharmacological perspective, like I've already outlined. And what we want to do is try to get these women in treatment and treat them through their pregnancy, and their pregnancy outcomes are much improved then. Next slide. All right, I didn't want to spend too much time with this. There's a lot of controversy still about whether or not they have to be on the mono product, Subutex. And the long and the short of it is, it's basically a lot of controversy, but you do not have to change patients to the mono product. A lot of patients think that it's like an absolute firm recommendation. It's not. In our hospital system now, sometimes that's occurring and sometimes not. So I think you could really do it either way. There was some interesting literature last year, I think, and this has been my experience too, one of the reasons that the paper discussed not changing them is because the naloxone is not dangerous to the baby. And it is difficult. It's difficult if women have been maintained on buprenorphine during their pregnancy. It's difficult to get them back to the Suboxone. Oftentimes that is difficult to do. So that's one reason to consider, not using the monoproduct sometimes. Next slide. And the medication, the buprenorphine, should be continued in and through the pregnancy, and there should be no interruption. Just like the pain things we talked about earlier this week, there should be no interruption in their care. If there's any kind of pain issues during their pregnancy, buprenorphine, and add to that whatever else needs to be done, of course, except for anything that has any kind of antagonist properties. Next slide. And again, this should be continued throughout and the postpartum period, treating their pain aggressively, properly. I mentioned it on the other day. Our hospital system does an excellent job with that now. Our obstetricians use multiple different interventions, and our rate of using opioids in these patients, particularly after C-sections, has decreased dramatically, and the pain experience has improved, actually. But, almost all options are on the table. Next slide. Just to be clear, women who are on methadone or buprenorphine can breastfeed, and in our hospital system, they are encouraged to breastfeed. I've done a lot of work with the neonatologist on this, and their only sort of contraindication to breastfeeding in these women is if they are using other substances. And frankly, there could be arguments made about this, but from my perspective, that seems reasonable. And so what I'm saying to you is our women who are on medication-assisted therapy and are not using other substances are encouraged to breastfeed. Probably helps somewhat with the neonatal abstinence syndrome, particularly the bonding and the closeness that helps the baby. And there's other benefits. And so it is encouraged in our system. Next slide. So obviously there's, in these patients, a lot of other comorbid, particularly mental health diagnoses. Next slide. And this is just giving sort of a general overview. Very, very common. Next slide. But this is really what I wanted to talk about. And I realize this isn't, comorbid mental health treatment necessarily, but the benzodiazepines are an extremely common issue and difficult to wrestle with. Our patients do have a very high incidence of anxiety, and it's oftentimes very difficult to know what to do with it. But what I see commonly is kind of an all or none type of approach, like either the patients are prescribed benzodiazepines without a lot of thought about the risks, and or our patients are told they never can ever have a benzodiazepine. And I don't think either of those things is really the right way to go. I think there's potentially a role, in general. Of course, we need to be concerned about the risk. Most patients the vast majority of patients with a sedative use disorder have an opiate use disorder. So these things run together. And so we have to be very mindful of that. And yet, in my experience of it, some of our patients do seem to do better on regular benzodiazepines. And so trying to balance out the risks and benefits here, I realize that really may not be easy to do. It really is not easy to do. I've done it, tried to do it many times. But I do think that it can be done with certain patients. One of the problems is there's really no good way to predict who might do well. And sometimes you have to, take the risk. I think a lot of the times people aren't willing to take the risk for the patients. And what I see that leads to a lot of the times is the patient's really struggling. Next slide. So these, as I mentioned, these patients are, commonly have comorbid anxiety. Once they start using the benzodiazepines, they oftentimes struggle with the physical dependence that develops with these as well. So it can be quite challenging to manage these patients. Next slide. But I put this slide, this is directly from the waiver trainings. And I think it's a good slide to remind ourselves, because I don't, if people remember, but I was in the throes of this in 2016 when the black box warning with benzodiazepines and opiates came out. And, you know, that's, of course, that's a, you know, a significant and reasonable, you know, concern, the concurrent use of these medications. Absolutely. But what I saw happen, and this happened across the country there by the update a year later, was that a lot of our patients were just discharged from their psychiatric care, like literally just discharged, because they happened to be on buprenorphine or methadone, and they were getting prescribed methadone or a benzodiazepine. Then this came out, and the mental health provider said, we can't treat you anymore. That was not the intention of that warning, all right? So the FDA reissued the guidance, you know, a year later, because so many patients were having trouble. They were either being removed from their medication-assisted therapies or removed from their benzodiazepines without any thought. And this, to me, this is really the more reasonable way to look at it, the follow-up guidance, particularly, you know, thinking about, okay, there is risk here, but I have to weigh that risk against all the other things, like their untreated opiate use disorder. And if the patients on the benzodiazepines, can they be removed? Maybe they can't. If I carefully monitor them, then we can certainly reduce some of the risks associated with this. So to me, that's the better way to approach this. Next slide. So this is basically what it comes down to. This is just more of the same, more of the FDA guidance, that even if they're on a benzodiazepine and buprenorphine, for the majority of these patients, continuing the buprenorphine, the benefits outweigh the downsides. And we can continue to struggle with the benzodiazepine use, but to me that falls into the category of what I've already been talking about, that that may take time. We can't expect patients to necessarily just stop like this. And with the benzodiazepines, it's often really a struggle for them. And I know if you've ever taken care of patients who are struggling with this, that you know what I'm talking about. It's not easy sometimes for them to stop taking the benzos. Next slide. All right, this is just more of sort of practice tips, like how can I manage these patients, like who have co-occurring disorders, especially if they're on a benzodiazepine. And the way that I do it is basically the way I've already been outlining: frequent visits, frequent assessment of how they're doing. That from my perspective, it appears that the initiation of this treatment has made things better, not worse. I limit the use of short-acting benzodiazepines. In my practice, we do not use Xanax. That is a quintessentially addicting medication, and that is very difficult for patients with a substance use disorder to manage, in my experience. So if we use a benzodiazepine, it's a longer acting benzodiazepine. Then we try to, you know, if I can, start to try to wean, but to recognize that that may not work, and that when we're talking about weaning, it's extended tapering, months or even longer, if there's going to be any success in this. And in my area here, like nobody's willing to do that with these patients usually. Say, you know, go to a detox for 5 days or something. That doesn't work well for the benzos. Next slide. All right. This is just another approach, and I sort of alluded to it, but this is from Israel, I think this study was. And I ran into a couple years ago. And this is one of the sort of ways that I manage it now in our opiate treatment program, that I work with some of the mental health providers, that if we sort of think like, okay, maybe the benzodiazepines are something that we need to consider here. Can we co-manage this? We use Klonopin. And that study talked about a mean dose where patients did fairly well, meaning they took the medications, there wasn't increased risk, and they weren't using other benzodiazepines. A mean dose of Klonopin around 2.5 milligrams. And so that's kind of the policy we have in our opiate treatment program now, that I'll work with you, with your mental health provider, doses 2 milligrams or less. And that has worked actually quite well for us. Not everyone wants to follow that, but it has helped a lot of the patients to be able to be more stable. Next slide. All right, I'll skip this one. Thank you. Next slide. All right, next slide. This is just a little on medical marijuana. I don't want to spend too much time on this. I don't purport to be an expert. Some of just my own sort of looking into this. This is an ongoing issue here in New York. What's its proper role? does it have a role, and all of those kinds of things. The way it was rolled out here in New York was very controversial. And, you know, there's not a ton of, frankly, good literature on the proper use of marijuana or what its proper role. There are a couple, the first couple bullet points here, there's a couple of disorders that really seem to have good benefit and good literature supporting it. But then there's a lot of conditions for which it's used, chronic pain, and in New York, it's now approved for the treatment of substance use disorder, for which there's no literature, you know, so that's very controversial, I'll say. Some of the patients seem to do okay with the medical cannabis, particularly some of the patients with anxiety. And as I said, even though there's not a ton on just chronic pain in general, some of the patients, and it's total anecdotal, seem to do better with the medical cannabis. Next slide. So this is, you know, the summary is, like I say, there's not a ton of hard literature out there. It's relatively scant. The best literature is for neuropathic pain that I could find. Next next slide. There is a risk, as most of you know, of using cannabis and having a cannabis use disorder. So it's not harmless. But as I've already alluded to, it's not in the same category as opiate use disorder either. So that's not to say that it has no consequences, but it's not as consequential to patients as, say, their untreated opiate use disorder. So, but we do have to balance those risks. How does medical cannabis fall in here? And the risk of addiction, as far as I know, that is unclear still. That is unclear. We're talking about smoked cannabis here. Next slide. This is qualifying conditions in New York, and I realize it's probably different for, you know, you in Maine. But just to give you a list, this is what a patient in New York can go to a doctor, have these things, chronic pain, obviously that's very broad, but also substance use disorder, including opiate use disorder. And the law in New York State is they can be prescribed medical cannabis. And so, you know, a lot of our patients have tried to do this, meaning get off medication-assisted therapy using medical cannabis, and that just does not work. Does not work. So we have to think about this all kind of reasonably. I kind of try to walk a middle ground with the medical cannabis. I don't prevent it, but, you know, I have, you know, ongoing conversations with the patients about it, the potential risks and benefits. And, you know, I don't condone non-prescribed cannabis use. Next slide. All right, so this, I've already talked about this. So, you know, not to say there's no pros, you know, that's the thing. This is, to me, this is a difficult topic because it is safe, generally speaking, but it is also not just risk-free either. And its proper role and really the benefit of it, to me, is not clear. And that's where it's at right now. Next slide. So this is a little script I found online, which I thought was pretty good. And this is basically the kind of conversation I have with patients that, you know, I don't recommend it. There may be, you know, there's some conditions, maybe it's helpful. If we're going to do it, we need to do it properly under the auspices of the New York State law. And there could be some downsides. And, you know, I've had pretty good success with this. I just was talking to a patient today who tried it and didn't like it, and they didn't do well with it. And, you know, then she stopped it. So, you know, I can live with that. I can live with that. Next slide. This is the last slide, and I'm going to be taking questions if there are any. You know, our patients are, well, they're a stigmatized population. And I realize everyone knows this, but this is part of what we should be trying to do is decrease the stigma, be mindful of how we speak about patients with a substance use disorder and our patients. Try to, you know, bring our colleagues along when we see, you know, that there's issues, because a lot of our patients have had real negative interactions with the medical system, frankly. And, you know, when I think about it, I've seen lots of crazy business, you know, in my time, and I can understand sometimes why the patients have negative thoughts about us sometimes, you know, honestly. And so it's really like, it's very important for us to work on this, to keep working on trying to make sure we we should be able to, and you know, I realize the analogy isn't perfect, but for the most part, why is a substance use disorder any different than any other disease that we treat all the time? And, you know, the long and short of it is it really isn't. And, you know, the more that we sort of look at it and we approach it that way and it's normalized as a treatment, to me, the better off everyone's going to be. So with that, I'll close and I'll take any questions now.
Also, if you're going to ask a question, if you could just make it at the bottom by the box, all panelists and attendees, so everyone can see the question when you type it in. Let's see. Yeah. Does anybody have a question? Let me make sure. I see where it's this whole raising hands thing. Okay. Okay, cool. Someone's typing.
All right, so do I tend to treat mostly younger patients? Absolutely, I do. I know over the course of time, the average age in our clinic has decreased. You know, basically that just goes along with the demographics of addiction in general. Addiction really is a disease of the young. Obviously, it affects all ages. Most patients with any addiction, really, if they're older, they've just had addiction for a long time. Not to say that, you know, the disease can be active, obviously can become active at any age, but most of the time it's that we start young and, you know, may not identify problems or whatever until we're much older. So we do see very, very young patients in a way that's like a little difficult, you know, sometimes. Particularly methadone used to be the last stop on the train, so to speak. Usually we would see patients after they've been in their addiction for years and years and have failed multiple other treatments multiple times. And honestly, though, thankfully, that's really not the case anymore. I think that is partially due to education. I mean, why does someone have to struggle through 10 years of using intravenous heroin before they get help? I mean, there's really no reason for that to occur. And so we are seeing a lot more younger patients access treatment, which, you know, ultimately I think is actually good. Do you ever get so, all right, that's a good question. Do I ever get so discouraged that I want to do something entirely different? No, I don't want to do anything entirely different, but I do get discouraged. Yes, absolutely I do. And, you know, I think the biggest discouragement that I have is that I really hate to have to watch what addiction does to people sometimes. Hopefully you know what I'm trying to say here. I mean, we're trying to help the patients and we are watching oftentimes what this does to people. And that's just can be so terrible, just terrible. But then the flip side of it, of course, is that we are able then to help people out of that. It's a hell on earth. And so, you know, yeah, sometimes it's pretty tough. Most days it's pretty great, actually, because most of the patients really do get better to some degree or another, And that's what I'm trying to, you know, stress to you. Usually it's not a straight shot. Like, oh, hi, nice to meet you. I'm Dr. Updike. Tomorrow the patient is completely abstinent, never to use drugs again. It doesn't work like that. It just doesn't work like that. This is a complicated disease we're talking about that has clear, significant physiologic abnormalities that are associated with it. But of course, also it's a learned behavior. There's a lot of things that the patients have to do to get well. And that takes time. There was a couple coming in now. I'm sorry.
There was a
how do I go back?
Can you see it?
I can't, let me see here. Oh, here we go. All right. So I have a patient who wants to get off buprenorphine, trying to take. He's taking 2 milligram cuts into 8s and a quarters. Urine's been negative for buprenorphine. I wonder if you have seen this with such a low dose. Yes, I have. It's unlikely. I mean, you know, listen, hopefully you all understand. I'm talking in a lot of generalities here. For the most part, I mean, I really try to paint the good picture because I honestly love my job, and it's a great job, and I see a lot of great things. But of course, things don't always work out the way we would like them to. But the vast majority of the times, I'm surprised at how well things go. That being said, it's not likely that people are diverting and scamming us to get, you know, 15 2-milligram strips a month. That's very unlikely. It's very unlikely. Now, you know, for a patient like this, I think you definitely could see at such low levels that they may be negative. They may not even be taking it every day. There's a lot. So I'm real tolerant with that kind of thing. They're working on weaning. And the end of the wean process, and I'm sure most of you know this, but whatever we're talking about, opiates, benzos, anything, the end is always the hardest. The end is the hardest. So it may be that patients struggle mightily with that. And, you know, I think to me, though, that too gets back, like, we want to be supportive. We so want to be supportive, 100%. But then I also, you know, I continue to have these conversations with the patients about maybe this is just not working for you. What are we gaining here? I mean, if you're stable on 2 milligrams of buprenorphine, why does that have to change your, you know, what are we gaining? You're putting yourself at risk. So many of the patients that I've managed lots of patients exactly like this question is talking about, even if they're able to eventually get off, they end up coming back, almost all of them, because it just wasn't working for them. So, you know, I'm not trying to discourage anyone there. Sometimes patients can wean, but it is very difficult, and I would be super patient with the process. All right. All right, so there's a question here about decreasing stigma and encouraging entrance into therapy. Yeah, you know, I'm not the greatest. I try to do a little summary there at the end. I mean, for me, the best way for me to decrease stigma is I only have control over myself. And to the staff, I say, in most days, I barely have that. So, but I really try to, you know, practice what I preach. The more that we treat these patients properly and treat this as like we would other diseases and try to be respectful and all the things we all want to do, I believe the more that we do that, the more that this becomes sort of mainstream, the more that it opens people up and that this becomes, you know, more normal, so to speak. That is why, honestly, I believe that is why we have younger patients. I do a lot of education here in Buffalo. And ultimately, that's what I want. I want patients to feel like accessing treatment is a positive thing for them, not the last-ditch effort. When I started methadone, that was the last thing anyone ever wanted to do was start at methadone. And that's why we never saw them until they were like 50 years old. And they'd already been using heroin for 20 years. It doesn't have to be like that. All right.
Oops, I lost my arrow. Hang on. Okay.
All right, there's a lot of questions now, so... All right, so what can you do when you can't seem to get through to someone? Well, that's a very good question. And my own, probably this is not going to be very helpful, but I sort of already alluded to what I do. I try to hang in there with them. And I know that seems real simplistic or whatever. And, you know, maybe in some ways not even easy, but that's what I try to do. I try to walk along with them. Because, you know, at least if they're with me, they have a chance, so to speak. And, you know, that doesn't mean that, you know, just continue to do things that, you know, aren't appropriate. Like I know they're selling their medicine every time and not taking it. You know, that's not what I'm talking about. But these patients sometimes struggle, particularly with other substance use. And, you know, like try to walk with them and continue to try. I think the best approach, because it's real easy. I mean, I know that you must all know this. What they hear all day, more or less, one way or another, is basically you're no good. You're no good. And what I try to tell them is, you're good. You are a good person with a bad problem. Because you are struggling, that does not make you bad. And this is to be expected. And to continue to try to encourage them that they they can get through this. And sometimes it takes a lot of time. And I use a lot of analogies like that. Like, you know what, you shouldn't, it's to be expected that you might be having struggles. Don't give up. And I encourage the positive all the time. I can't tell you how many times the patients thank me because I simply say, good job, you're doing great. You really think so? No one's ever said that to me. That's sad. You know, it's really something. It's really something for some of these patients, what they accomplish. It's amazing when you think about it. And so I think it's awesome. I think it's perfectly legitimate for us to point that out. Good work. Don't get complacent, but nice work. All right. All right, so this may seem off topic, but what else do patients need? Well, that's not off topic, I don't think. It wasn't exactly the topic of this, but I think, and so you're talking about education, training, employment, support services, healthcare. Woo, that's a lot. And, you know, basically, I think most people probably do understand our patients are a very vulnerable population. Many of them need all of these services. And I applaud you for thinking about this. I wish we did a better job of that. As it currently stands in our treatment programs, it's a little bit haphazard. And I really am working on trying to make that better, that the patients have better access to these other services that are very important and that so many of them need. We do have much better collaboration, particularly with the housing now than we used to. And I don't want to make it too easy on myself here, but one of the things I focus on, because I can't control everything, of course, is that I really focus on, well, let's at least deliver their addiction treatment as best that I can, because what I know about addiction is this, that in the face of their untreated addiction, none of these other things are going to happen either. So to facilitate even being able to address all these other things, we have to get patients to a more stable place usually. So that's where, to me, it starts. But yeah, all of these things, in the ideal world, all of these services would be happening together. All right. I don't have any particular recommendations about the other stimulant use and or drug use in particular. Unfortunately, and methamphetamine use is heading east here. And, you know, it's becoming a bigger and bigger problem. I don't have any particular thing. We're left with kind of traditional, if you will, or standard substance use treatment. And that's what we should be encouraging the patients to do. It's a challenge. I believe patients get there if they continue to try, though. That's what I believe. And that's what I continue to try to encourage. We don't have any medication-assisted therapies. Of course, I'm exaggerating a little, but in comparison to what we have for opiates for other substances. So it's a difficult challenge. Is there a push to do more education in schools? There is in this area. You know, it only goes so far. I don't want to be Mr. Negative Pants here, but one of the issues with addiction is that it is a disease of the young, and some of that is just the physiology of adolescence. You know, the frontal lobes are not developed very well, and you can talk to them a lot about risk, and it doesn't get through that well. Not to say we shouldn't be doing it. And there is a lot more education about the risks of opiates in this area. Has that helped? I don't know. I'm not sure, to be honest with you. All right, so do you have recovery coaches in your facility? Actually, we do not, but what we have here is Save the Michaels, it's called, and it's a peer-run organization started actually by a family whose son had died from opiate use disorder, and they do a lot of that work. They bring patients to our clinic. So we have excellent partners that way in this area, but not directly that work with us. Okay.
There's one more question. I think you might have hopped over it. Where did it go? It was Anne's. How often do you see early childhood trauma associated with addiction? Did we?
Oh boy. Oh my goodness. I mean, I don't know. Is it just exaggeration to say like in every case? I mean, the adverse childhood events, I mean, is some, I mean, most of you know, I think, is one of the most significant risk factors. So, I mean, this is extremely, extremely common. So, I mean, the vast majority of our patients have that, we in Buffalo also had it's not unique, but kind of unique situation where we had very, very high level of opiate prescribing. We had the largest pain practice actually in New York State in Buffalo, and then a very aggressive legal interventions here. And I mean, patients just abandoned left and right. And so we have a very high percentage of patients here that are like that too. So a lot of early childhood trauma. And then we have a subset of patients, a huge subset of patients, exposure to opiate because of a chronic pain condition, and then unable to get opiates any longer, one way or another, and end up having then opiate use disorder as well.
Right.
So it's, I think we're to our time, but
Yep.
as was mentioned, my email, you can email me, you can share my phone number, you could call me if there's any problems or questions. I would always do my best to try to help if I can.
Yep. And thank you again. Fantastic. Really appreciate it, Dr. Updike. Have a good night, everybody. We're done.
Thank you. All right. Good
Bye.
night. See you.